Okay, it's shortly after 6 o'clock, and I think we should probably get started. You're very welcome to this Wednesday evening webinar, which has become part of, certainly has become part of my regular week. And for many of our members and fellows around Ireland and indeed abroad, it has become a regular session. And as I was saying before we went started the meeting, that we regularly now have up to 300 and sometimes over 300 people online on a Wednesday evening, which is great. And I hope that many of you will have at least attended some of the recent charter meeting, which I think was transformative, with over 3,000 people registered and up to over 600 at some individual sessions. And even the Saturday morning session had over 200 with the Irish surgical trainees, and we would never have had that type of attendance. And so we've got used to using the chat function, which I would encourage those listening in this evening to use, because I'm able to pick up on it and then to ask our speakers on your behalf questions. And please do feel free to use it, because now that we've become accustomed to it, it really does work quite well. And it does prevent us speaking over each other, which is a problem with this webinar technology. We're going to this evening talk to 3 of our alumni who are established in the UK in consultant practice, and want to hear really about your experiences of what COVID has done to your practice, what it's done to teaching and learning. And I'm not particularly inquiring, but you can talk about family life and recreational activities if you wish as well. But it certainly has made a big impact here, and I'm sure it's no different in the UK. So the first person we're going to introduce this evening is Paul Horg. Paul and I go back a long way, all the way back to when I was a registrar in Cork. And I think, Paul, you were an SHO, and we've worked closely together as registrar and senior registrar and consultant. And then I had the pleasure of you being an external examiner in UCD and in Penang. When I was professor of surgery in St. Vincent's. Paul, you were a great loss to Irish surgery, a great gain for Scottish surgery, and you have done exceedingly well in your career, and now are head of the academic unit of surgery in the University of Glasgow. So, Paul, we'd be very interested to hear the effects of COVID-19 and Brexit on surgery in Scotland. Thank you, Paul. Paul, you might still be muted. We can't hear you. Paul, I can see on the screen that your microphone is still muted. If Pauline Lyons is in the background, Pauline, is there any way we can unmute him remotely?
Prof, I just tried there and I can't. I think he has to do that on his side.
Let me see if I can phone him. Otherwise, we might just bring up Siobhan O'Callaghan's talk. Do you have the slides, Pauline?
Sure, yeah, one moment now.
Paul, we can't hear you. While we're trying to sort out Paul, we're going to move on to Siobhan. Siobhan is a consultant plastic and reconstructive surgeon in Manchester, and we would be very interested to hear your take on how COVID has affected plastic and reconstructive surgery in the UK. Nice to see you, and thank you for joining us this evening.
Thank you very much, Professor O'Connell. Thank you for inviting me to speak about plastic surgery in the UK. Can I have the next slide, please, Pauline? So, plastic surgery is a relatively small specialty, but it does encompass a broad surgical field, incorporating reconstruction throughout the body. We've traditionally been concentrated in a few units in the larger urban centres, providing a hub and spoke service to hospitals in the larger catchment area. We're also core members of many MDTs, which some of you may be involved in. In the larger units, we're usually very subspecialised, and my practice is predominantly microsurgical breast reconstruction, but I also have a hand in soft tissue trauma commitment as well. Next slide, please. So as with all surgical specialties, plastics was hit hard by the initial wave when there was a total cessation of elective surgery. This was especially significant with cancer services, whereby no reconstruction was possible except were functionally essential. Burn services were consolidated to fewer centres to free up ICU bed capacity. And most plastics units lost theatre provision and ward space, either totally or partially. But this was very region dependent. Skilled theatre and specialist nurses were redeployed to the COVID wards or to ICU. And we also experienced delays in transferring urgent trauma patients, such as lower limb fractures, because of issues with COVID testing. Next slide, please. So, due to a lack of available anaesthetists, there was practically no capacity to accommodate day-to-day hand trauma. So many units moved their trauma off-site from the acute hospitals to smaller community-based facilities, with local anaesthesia becoming the norm.
Siobhan, I'm just going to come across you because I think there is somebody, maybe Louis Collum has got his microphone on and it's coming across with noise that is interfering with the reception for the rest of us. So maybe Louis, you could you mute your microphone.
Yeah, sure. Just give it a tap. Is that right?
I think so. There you go. Well done. Thanks, Siobhan.
Okay. So as with other specialties, junior doctors were redeployed to COVID wards and consultants acted down to cover rota gaps. And certain pediatric facilities, consultants actually had to provide resident on call, which came as a great shock to them. But major reconstruction was mainly restricted to trauma, such as revascularizations, replantations, and lower limb reconstruction. Next slide, please. So this graph shows the dramatic fall off in major microsurgical cases indicated in the dark orange line from the 17th of March, when the UK government announced the cessation of non-urgent elective surgery, and also from the 15th of April, when all elective surgery was cancelled in the UK and Ireland. So the number of emergency procedures indicated by the green line on the graph remained relatively unchanged. Next slide, please. So you're probably all familiar with this, this paper from the Lancet in May, which caused a great deal of consternation amongst all specialties. Over 1,000 patients undergoing any type of surgery who tested positive for COVID-19 perioperatively showed a frighteningly high 30-day overall mortality rate of 23%. And post-op pulmonary complications occurred in half these patients, accounting for 80% of all deaths. And this followed on from an earlier paper from Wuhan, which quoted similar mortality rates. So these frightening figures were a major barrier to restarting reconstructive surgery, especially for breast patients. But the limitation of this study was that it just looked at perioperative COVID-positive patients undergoing all types of surgery, which didn't really reflect the situation on the ground, where elective patients would have been pre-screened and postponed if they were COVID positive. Next slide, please. So because of the widespread delay of operations for cancer, trauma and functional restitution, this has resulted in increased morbidity and mortality across all specialties. So to get some objective data on the safety of major reconstructive surgery during the first wave, all 70 plastic surgery units in the UK and Ireland participated in a study of their major cases, be they free flaps or pedicle flaps, replantations, etc. And this took place between the 1st of March and the 31st of May, so really in the first wave. And a total of 418 patients underwent major reconstructive surgery in 64 units out of the 70. And cancer and trauma were the most common indications. Next slide, please. So COVID-19 infection was present in approximately 5% of patients, and the 30-day post-op mortality rate was 0.2%. And this was actually one patient who died who was COVID negative. 8 healthcare professionals developed COVID, and this was early on before PPE was properly provided. But COVID status didn't correlate with major or minor complications, and the post-op outcomes were similar to pre-COVID figures, as evidenced by the UK National Flap Registry. So this gave us some relevant data to allow restoration of elective major reconstructive surgery and to give our patients an accurate risk for informed consent purposes, and also to argue the point with managers that it was a safe procedure to reinstitute. Can I have the next slide, please? So with the introduction of perioperative testing and COVID green pathways, this facilitated the reintroduction of major recon surgery and other elective cases, but there was significant regional variation. And pressure from ABS and our own society, BAPRAS, it also succeeded in redesignating immediate breast reconstruction from P4 priority to P2 and risk-reducing surgery to P3. So that gave a major boost. Can I have the next slide, please? So with regard to changes to practice, from July to September, depending on where you were in the country, the South definitely got going faster than the North, and that's still the case today. Most units did get going again with major surgery, albeit with strict exclusion criteria and specifically designed COVID pathways to minimize the length of stay. Major surgery has been performed to a high standard, but there's been multiple challenges inside and outside the operating theatre, including unfamiliar theatres, delayed start times, increased changeover times, confusion regarding testing, PPE, constantly evolving PPE requirements, and communication difficulties while wearing PPE. Some units managed to purchase capacity in the private sector, but generally, with few exceptions, this was low complexity cases only. And then again, in mid-January, elective surgery was paused again in most units in response to the third wave. Next slide, please. So obviously, there's been a massive impact on our trainees. They've had loss of training opportunities from the disruption of elective operating. Many of them have been redeployed, mainly the junior surgeons, the core trainees and the junior registrars. But the senior registrars have also had to act down to cover their rotas. Out of programme trainees who were on fellowship for research or clinical fellowships have been recalled to their host regions, to staff rotas or for redeployment. And national selection has been impacted in that self-scoring forms were only used across all specialties in the recruitment rounds. So this has a big impact on the small specialties such as plastics. So we have introduced...
Yeah, so will I just mute it again or will I just leave it alone?
My apologies, Siobhan. We were trying to fix things in the background.
I understand. Do you want me to pause?
No, please go ahead.
Okay, sorry. Okay, so many of our trainees go abroad for fellowships, and they've all been cancelled. Even our own fellowships in the UK, the volume and opportunity is being significantly affected. Our own breast microsurgery fellowship in Manchester, we've had to extend the tenure of our current fellow because, well, he's not really had much opportunity so far. Courses and conferences almost all cancelled or moved online, and exams have been impacted either by cancellation or Part 2 exams have been changed to no patient contact and performed in hotels rather than clinical areas. But I think this is the problem for all specialties. And our junior doctor rotations have all been changed and deferred to try and minimize the disruption and maximize service commitment. Next slide, please. So we don't talk much about mental health, but we didn't before the pandemic. But trainees it's really impacted on trainees and to a certain extent trainers as well. They've had to adapt to new working patterns. We've had difficulty getting some of the private hospitals to recognise our trainees as operating surgeons. That's also regional dependent. Their long-term career plans are put in jeopardy and it causes immense anxiety for them. Family life's been disrupted due to their changes in rotas, schools being closed, childcare issues, and also the death of colleagues to COVID. We lost one of our own SHOs in the summer, which really impacted on our junior doctor team. Can I have the next slide, please? So you may be familiar with this COVID STAR, COVID-19 impact on surgical training and recovery planning. It was a collaborative national study of trainees across all specialties via their trainee associations. Next slide, please. And of our trainees, 51 responded, with almost all reporting reduced clinic exposure, changes in rota patterns, and half of them felt they would need an extension to their training. And there was also concerns raised about patient safety and physical and especially mental health issues. And 5 out of 51 trainees wanted to leave medicine altogether, which is quite stunning. Next slide, please. But it's not all been doom and gloom. There have been some opportunities amongst all the negatives. The miraculous dissolution of NHS red tape in one fell swoop has enabled many units to realise a long-held ambition of creating a direct referral one-stop hand trauma clinic, combining medical assessment, radiology, surgery and therapy on the one day. By relocating away from the COVID red zones, this has made this possible. WALANT anesthesia, it stands for wide awake local anesthetic, no tourniquet, and this has become the new norm for hand trauma. It involves using a tumescent technique of local anesthetic with adrenaline, and it negates the need for a tourniquet and an anaesthetist in routine hand trauma, such as fractures or flexor tendon repairs. All MDTs are now remote, and this has enabled plastic surgeons to establish links with previously poorly served spoke units where they were unable to supply a physical presence at meetings. And also the revolution in digital connectivity, such as WhatsApp groups and webinars. And it's enabled more widespread sharing of best practice information between units. And it's encouraged streamlining of enhanced recovery pathways to reduce length of stay. Next slide, please. So video clinics were virtually unheard of before the pandemic, and they're now widespread. It's ideal for skin cancer services as it facilitates direct referrals from dermatologists, and it streamlines the see and treat pathway considerably. With hand surgery, it's made it possible to provide remote physiotherapy sessions, but it's not always as appropriate for breast reconstruction patients for obvious reasons. Digital advances in encrypted referral pathways have made online trauma referrals routine, eliminates the risk of referrals being lost by a busy SHO on call. And digital photography sharing apps such as Pando facilitate communication between teams and consultants. And also teaching programs have been allowed to continue to some extent. Next slide, please. So there have been some opportunities for trainees presented by the pandemic, including new ways of learning via webinars, conferences, development of microscope labs, which have enabled them to keep up their microsurgical skills in a COVID-safe way. They've also gained knowledge of modified surgical techniques, as I previously just mentioned. And the reorganization of services has given them some opportunities to gain some leadership and management experience. And they've also gained some new skills during redeployment to ICU. Next slide, please. So the recovery presents many challenges for plastic surgery. There's an immense backlog of cases on the waiting list. It's built up. Our own trust estimates approximately 3 years of workload has built up in the last year. Many displaced units have concerns about re-establishing their prior footprint, with many estates being used by other services. For example, our theatres are being used by endoscopy, and that's been the case since June. So with yet another reorganisation of the NHS imminent, there are concerns about changing management priorities and if all aspects of plastic surgery service will be retained in all areas. Are we facing the infamous postcode lottery again? With many skilled nursing staff sent to other areas, will we be able to retain the skilled plastic surgery, theatre and ward staff post-pandemic? And changes to working practices and job plans are likely to persist, such as dual consultant operating for major cases to facilitate throughput. This will have an impact on training with pressures for efficiency. However, hopefully, with the rollout of the vaccine, there'll be some light at the end of the tunnel. And the next slide just says thank you.
Well, Siobhan, apologies for the interruptions and for parachuting you into
I think that was good because I didn't get a chance to get nervous.
So you raised a lot of issues there, and I've jotted down some things that we will come back to in discussion. And I would ask those of you who are interested in sending a question, please use the chat function. I've had no questions in yet. Don't worry, I've jotted down plenty, so we'll have plenty of material if it needs be. So can we then, now that Paul has regained his voice, we look forward to hearing from you, Paul, and the floor is yours.
Thank you, Ronan, and I apologise for being unable to unmute the computer screen, but apparently you can hear me now, which is really quite good. Thank you very much for asking me to contribute to your excellent webinar series in these really quite extraordinary times. So my brief for 10 minutes or so was to look at the effects of COVID-19 and Brexit on surgery in Scotland. Next slide, please. So you need a little bit of background when you want to look at the effects on Scottish NHS, because the Scottish NHS has basically devolved to the Scottish government from Westminster. So it does its own thing. It's got its own lockdowns, its own rules, regards to schools, universities, and activities. And the background to it is quite interesting in that the known factors that we have is the referendum on Scottish independence in 2014, when the predominant reason that Scotland did not vote to become independent was because they did not want to leave the EU. And leaving the England at that time would have meant leaving the EU, and this raised its head again when it came to the Brexit vote then in 2016, when the main reason that Scotland voted to remain was because they did not want to leave the European Union. So Scotland is very pro-EU in this regard. The unknowns then that have occurred over the past year, of course, is the evolution of this zoonotic disease in the wet markets in Wuhan, and that's created complete havoc and devastation as far as the NHS and surgical training is concerned in Scotland. And then we've got lots of unknown unknowns as Brexit has just suddenly hit us since January the 1st. Next slide, please. Thank you. So I'm just going to look at 4 aspects, and I think all 3 of us as presenters will have to concentrate on the same things, even though I think Scotland is different and unique. So we'll just look at the effects of COVID and Brexit on NHS activity, on undergraduate training, on postgraduate training, and finally on surgical research quite briefly. Next slide, please, Pauline. Just to summarise, I suppose, the overall effect, you can just look at this particular diagram. This is a diagram by the Scottish Government, and it looks at NHS activity for 10 years since 2012, well, probably 8 years since 2012. But essentially, if you look at the blue shaded areas and just look at the green line on top, it just tells you the kind of patient journeys that you had and the length of time it took to achieve them. So if we look at the blue graphs, for example, you can see that the number of patient interactions have been similar over the entire 8-year period, and then suddenly halfway through last year, it just catastrophically falls from a cliff. And the green line on top signifies the number of those patients that were treated within 18 weeks. And again, this has fallen off the cliff and gradually increased. So that slide just summarises just how bad the effect has been on us. Next slide, please. Thank you. So if we just look at the effect of COVID first on NHS activity, as I just mentioned, a catastrophic fall occurred in the number of patient journeys since February and March of 2020. All screening stopped, so cervical, breast, and in particular colorectal screening was just halted. And there was a devastating impact on the wait for inpatient treatment. Now, it wasn't brilliant before COVID, but COVID has really exaggerated. So the proportion of patients that were waiting longer than 39 weeks for inpatient treatment doubled over a 6-month period. So in June, which reflected the beginning of the year, it was approximately 11.4%, and it doubled in September to 23%, and that was during the second surge of the pandemic. And the number of patients waiting longer than 52 weeks is now increasing. Now it currently stands at about 35%. And that may seem like a dreadful number, but it underestimates exactly just how bad it is, because patients weren't complaining of their symptoms, even if they were significant cancer symptoms. They weren't going to their GP because the GP practices weren't doing face-to-face, they were doing telephone interviews, etc. They weren't being sent to surgical clinics because face-to-face surgical clinics stopped. And they weren't being investigated by obviously colonoscopy and endoscopy. So the numbers are much higher than we're looking at. Next slide, please. Thank you. Now, when we look at the effect of Brexit in addition to COVID on NHS activity, it has made quite a difference. A large number of EU workers have left the NHS since 2016, and this is especially accelerated in 2020. It has had an unusually and unexpected side effect in that the NHS are now actively recruiting out with the EU. So they're appealing to the Middle East, Far East, South America and North American markets, and they weren't able to do this pre-Brexit. So this might actually have a positive effect on recruitment, but not within the EU. It has had no effect on drugs and medicines availability as yet. However, it really is only since the 1st of January that we have the customs and the ports restrictions, and there has been an element of stockpiling in the 6 months leading up to the actual Brexit date. So I think we have to wait and see what the outcome of that is going to be in the longer term. Next slide, please. Now, when we look at the effect of COVID on our undergraduate education, the picture, by the way, is the Wolfson Medical School in Glasgow. We can see that there's been a huge explosion in the use of electronic teaching methods, and it has overall been quite successful. What hasn't been successful is the number of clinical exposures that our undergraduate medical students can have. They've been kept away from clinics, kept away from theatres, kept away from wards, particularly the wards that are overwhelmed with COVID patients. And this has resulted in a decreased clinical exposure for them. Again, an unexpected side effect has been that the students appear to have more supervisor contact, and the supervisors appear to have more interest in them than they had pre-COVID. And the supervisors have little to do in addition to the students. And as a result, students are actually getting better teaching in this regard. Graduation has been virtual, and it's happened earlier last year. They graduated in April and were put onto the wards as quickly as possible, and this has been very successful. The plan this year is to do the same thing. GMC outcomes have been satisfied, and the university and the GMC are satisfied with the way this is progressing. Next slide, please. What effect has Brexit had on our undergraduate education? Well, income's has changed. Scottish students traditionally did not pay for their university education, and everybody else did. EU people had special rates, but since Brexit, only the Scottish get preferential rates in the universities. So all of the students are now treated as overseas students. It was expected that the universities would take a huge hit as a result of this quite seismic change. And there are some universities in the UK that appear to be particularly exposed by the high numbers of overseas students that they have, and Manchester is one of those, and Glasgow certainly was another one. However, it doesn't appear to have materialised, and the university are reporting a continuation of overseas student applications from the Middle East, Far East, and people are signing into our regular conferences from Singapore and from Kuala Lumpur, and it does not appear to have had a negative impact at this particular point. It has had an impact on diversity within the university. There are much fewer EU students now enrolling in the university, and this will have long-term diversity implications, and that can't be minimised. With the loss of EU closeness, the universities have had to depend quite a bit on the Guild of European Universities, and this is reported to be quite successful. Next slide, please. When we look at COVID and surgical training, in Scotland, our trainees, our senior trainees run from surgical trainee 3 to surgical trainee 8, which time they can do their exam and CCT. The groups that are most affected by COVID are those ST3s and the ST8s. The ST3s don't get to do the simple, straightforward, benign operations like lap choles and appendices that they need to do. There are no hernias being done and almost no elective cholecystectomies. The ST8s also suffer as they have difficulty in achieving their numbers that they need for their logbooks in order to sit their exam and CCT successfully. There continue to be major cancer resections performed, and they have been done since last March, but almost no benign procedures. So there is a big difference in the range and the breadth of what they're able to do. Emergency activity has continued almost unaffected, except it's slower, more pedantic, and with greater care for pre and particularly for post-operative care. Our trainees are reporting that the quality of teaching has possibly improved over the last year. And again, similar to the undergraduate situation, this is probably due to increased supervisor input. Consultant surgeons appear to be happier to assist their senior trainees understanding the effect of the decreased activity, and trainees are reporting good results in this regard. You may or may not be familiar that private medicine is completely separate from public medicine in the Scottish NHS, but the private hospitals have been recruited to be used for public use. For example, one of the private hospital groups were employed to do all the breast cancer surgery since March of last year, and this has been very successful. And as a consequence, our trainees have been shipped to the private hospitals for the first time, and this has worked very well. And as mentioned earlier, there is an effect on post-CCT fellowships. We're not getting the people that we were told we were getting from Australia and the States, and we can send people to the fellowships that have been arranged for them for various reasons. It may be because of borders, it may be because of quarantines, there may be difficulties with families, and of course there is decreased activity in all hospitals in different parts of the world, and it may not be sensible for them to go. I think this will improve with time, but at the moment it's certainly a problem. Next slide, please. There are differences in surgical specialities. Trauma and orthopedics is basically just trauma. There isn't any elective orthopedics being performed. ENT is just cancer surgery with excessive PPE protection. Upper GI surgery the same. Colorectal surgery, all benign stuff stopped at the beginning. we were forbidden from doing routine colonoscopies, but the rules for that were relaxed quite quickly when it became clear that there really wasn't significant risk in this setting. Cardiothoracic surgery in Scotland is done in different hospitals to the main hospitals, and as such that was relatively untouched. And one of the, again, unexpected side effects of all this decrease in activity was that there was an increase in investment in robots, and there's a number of them being distributed to different health boards as we speak, this week in fact, and an increase in the number of endoscopy simulators that have been provided as patient contact has been reduced. So once again, every cloud appears to have a silver lining. Next slide, please. So what effect has Brexit had on surgical training? Well, there are barriers to recruitment, visas, work permits. It's all different now, and it's a different world. So this has caused immediate issues. But it has increased the potential for non-EU recruitment of trainees into training slots from other markets which weren't available to us under EU rules. So once again, it's going to be a mixed bag with positives and negatives. Next slide, please. Next slide, please, Polly. I appear to be stuck on Brexit and trading. Can we get the next slide, please? Yeah, thank you. And finally, Brexit and surgical research. Well, funding has been significantly curtailed with regard to EU sources of funding, and cooperation with former EU partners has also been curtailed, and this has reduced cross-employment and cross-fertilization of resources. So it is definitely going to have an impact on surgical research. Next slide, please. Thank you. So in summary, COVID and Brexit, individually and together, has had severe effects on medical education, on training, on patient activity, and on research. And as mentioned earlier, and I'm sure everybody's going to say at the end of their talk, the vaccine does offer optimism, although this is another unknown. Final slide, thank you. And this is a picture of my hospital in its Sunday close. It doesn't usually look like this, but it looks good in this particular picture. So thank you very much.
Thank you, Paul. And you've covered a wide range, including the effect on undergraduate, postgraduate education, and of course research. And we may come back to that later on. One question has come in from Paul Balfe. Thanks, Paul, for a great presentation. In the interest of speed, is it expected that during COVID-19, the consultant will do the emergency cases? Paul, what's happening in Scotland?
Yeah, that's an interesting question. No, not in the interest of speed. The whole process was dramatically slowed down is the issue, with excessive anaesthetic requirements, very long delays both during and particularly after surgery with deep cleansing of theatres. So no, speed has just been very slow. And the comment of our trainees has been that consultant surgeons, while there, are very good for assisting their juniors in training cases under these circumstances, knowing that they're losing out so badly this year. So I think the answer is actually positive rather than negative.
Yeah, I think that's the paradox, actually, that the training opportunities when they're there are actually better. There may not be as many, but the quality of the training is better.
Absolutely.
Can I welcome Kieran Walsh, who is coming to us from the Wirral, and Kieran, graduate. Kieran, you're an RCSI graduate, I think, as well.
I am.
And long-standing friend and colorectal surgeon. So, Kieran, we're looking forward to hearing from you on what's happening in the Wirral and around Liverpool.
Thank you very much. Thanks, Mr. President, for the opportunity to join your series. I took the view that coming third that much of what I had to say you'd already have heard, and indeed I would echo practically everything that I've heard. My experiences are the same, but whilst I thought that many of you would know where next slide, please, where Glasgow and Manchester were, I thought you mightn't be so sure where the Wirral was. And it's this little peninsula between Liverpool and North Wales with a river on either side, two cathedrals, two liver birds, two football clubs, and this hospital that I've discovered this evening that Laura Vianney worked in called Arrow Park Hospital. Next slide, please. And it was in this hospital on the 24th of January that my COVID story begins. And I've no idea why, but don't ask me why. I was giving this lecture, and this is the very first slide of that lecture. Next slide, please. And sure enough, this was my second slide. I'd heard about coronavirus. I certainly hadn't heard the phrase COVID-19. And I was familiar with the iPhone, and I was familiar with the train journey from Shenzhou to Wuhan. Next slide, please. And that was because just over a year previous or prior to that, I'd been in Chongqing with a couple of guys talking about our stage 4 colorectal cancer model that we use on Merseyside. And I had a sense of place, and I had a sense of, as I said, of Shenzhou. Next slide, please, of Shenzhou. And I just modified that second slide I showed in my talk because I hadn't realized that Shenzhou makes half the iPhones in the world, this huge factory city. And the bullet train that goes from Shenzhou to Wuhan and vice versa, takes just under 2 hours. And it struck me, I have absolutely no idea why, that this was going to be very important. And though in the connectivity in the world, I couldn't get a sense this disease could be contained. Now, obviously, you appreciate as a colorectal surgeon, I know absolutely diddly squat about virology. So I thought all these viral particles might survive in the iPhones. But the concept of the disease spreading didn't escape me. Next slide, please. But I certainly didn't realize that 6 days later, on the 30th of January, these headlines would be coming in the press, that there'd be 100 residents of expats from Wuhan be coming back to the UK to quarantine. And I sure as heck didn't realize they were coming to my hospital. So they did. They came from Wuhan. They flew from Wuhan to Brize Norton. Next slide, please. They flew down over the Wirral down south. And on the right here, you'll see the back of our hospital and the accommodation block, which was rapidly cleared to accommodate these guys. And then with great fanfare and flashing lights, 3 coaches came up from south to north. Now, you may not be able to see, I don't know if it transmits or not, but I don't know if you can see the things that strike me about the slide on the left is that the person at the front who isn't driving is wearing a hazmat suit, and the one who is driving is just wearing a tank top. And that pretty much summed up the confusion and what we were meant to be doing with the coronavirus at the time. And the wags on Merseyside couldn't resist the temptation to spot that the company running this bus company was called Horseman. So they thought we'd been shortchanged up north. They were only sending us 3 of the 4 horsemen of the apocalypse. So next slide, please. They clearly weren't that wrong. It has been apocalyptic. And I think that number now has gone up to 114,000 deaths in the UK. I used this date of just over 100 because it was exactly almost to the day a year after I gave that lecture at Arrow Park. And for me, UK surgical perspectives have to sit within national perspectives. And the thing that haunts me personally is the prediction by Richard Horton, the Lancet editor, on March 2020 about an avoidable calamity and his consistent message, and now talking about what was a preventable calamity. So as a medic in the UK, there's a lot to take in, there's a lot to try and absorb, and trying to work out what we might have done differently. Next slide, please. It is clearly the case, however, that there's something to do in the future. There are currently as many people waiting for elective surgery in the UK as there are citizens of the Republic of Ireland. I think the region, you have around 4.9 million. I think we're running at about 4.7 waiting for some sort of an operation. Neil Mortensen said, as our president of the Royal College of Surgeons in England said recently on Newsnight, you can't make this up by just doing what we did and a bit more. You can't do what we did and add 10, 15 or 20%. We're not going to get back. We're not going to catch up. Next slide, please. But for now, this is my hospital. It's the land of the COVID command dashboard, gold, silver, platinum command, chains of command, measuring this to do with COVID, that to do with COVID. We measure cases, we measure our critical care footprint. It all comes out on a daily basis. We're measuring site oxygen consumption. Next slide, please. And I put this in because this was actually one of the great success stories of our trust in the first wave, because we had a problem with oxygen and our trust really got off their got their act together and sorted it out, and this was a really a great success story. Next slide, please. It wasn't all a success though in the trust early on. I show you this ACP slide, the Association of Coloproctology, because at this time I was on the executive of the Association of Coloproctology, and we were under the tremendous leadership from Nicola Fernhead, and we were really working night and day trying to produce guidance for colorectal surgeons in the UK and in Ireland, members of the Association of Coloproctology. Next slide, please. But the slightly distressing reality and harsh reality was that it didn't matter, because if it didn't come from Public Health England or NHS England, it didn't exist. And that was one of the big take-home messages for me. And it brings into question the role of professional societies and indeed colleges when it comes to really key and core decisions. Next slide, please. I also had the opportunity, along with other members of ACP and indeed Professor McNamara from Beaumont and RCSI, to work in this ACP Legacy Working Group. There was a real sense that COVID was acting as almost like a solvent that was dissolving the grouting between the tiles in the NHS, and the tiles were falling off the wall and landing on our feet in the shower. And it hurt. And it was quite apparent that this wasn't all just due to COVID. There was a lot that was wrong that was before it, and it had been exposed by COVID. Next slide, please. So this Legacy Working Group looked at things that might be taken from changes that COVID induced and how we could bring this into practice in the future. Looking at the concept of personalized, realistic shared decision making with patients rather than just doing invasive testing on everybody who arrives at our doorstep. There was a great excitement about fecal immunochemical testing. We have in the UK a thing called a 2-week wait pathway for rapid access for high-risk patients. But you know, it only produces about 3% or thereabouts of our cancers. And we pour an inordinate resource into it. And fit in primary care might be an answer. The value of telephone clinics, particularly in rural communities and in the frail and elderly in urban communities, people not having to come to hospital, you could help triage them, and so on and so on. Flattening of hierarchy, I think, was a real eye-opener in COVID in the first wave, and it's persisted in our trust, and it's been of great benefit. And I think that the trainees have benefited and the consultants have benefited. There's been a real problem with trainee in exposure as regard to craft specialty interaction. But in terms of becoming a doctor, I think a lot of things have actually improved, and doctors have been empowered to make doctory decisions without their managers over their shoulders. Next slide, please. I reckon that I could quite simply change outpatient colorectal practice with one of these 6 things, all of these 6 things. A nurse, a safety netting system, a telephone, a couple of poo tests and a blood test. And we could save so many people coming to hospital, and we could design a system whether you were either routine, urgent or an emergency. Next slide, please. So at the moment in the 3rd surge, like everywhere else in the UK, we're a colour-coded hospital. We turn left to go this way, we turn right to go that way. It's a silver ward, it's a green ward, and everybody gets confused but tries very hard. We're doing some P2 oncology cases. The target in our hospital is we'll be up to an elective surgical activity the 2nd week in March. That waits to be seen. Siobhan mentioned about the COVID surge data from Anil Bangu and the group published in the Lancet. We didn't see that realised at Wirral Trust, and we're not seeing it now as we've been working hard to put through some elective cases in this surge. So we're busy as surgeons doing our face-to-face clinics and our telephone clinics. And when we're not doing that, we're spending quite a bit of time on proning rotas, learning how to use macerators in the sluices in the ITU, and vaccinating people. Sadly, we're struggling with FIT because we have it in secondary care, which in my opinion it shouldn't be. It should be in primary care. So we're still processing all those people in secondary care. But some good things, we're vaccinating our colorectal cases at diagnosis. And we feel that vaccination is permitting a better clinical decision making for elder and frail people. As regards emergency surgery, we've abandoned some of the changes that we made in the first surge as regards processes on the appendicectomy pathway, conservative management. We've abandoned the cholecystostomy in acute cholecystitis. That wasn't a great success in our hands. And quite frankly, I found that in emergency surgery, the God hat is even harder to wear. It was always hard to wear. It was always hard to say to that 85-year-old who was frail and their family that the easy thing was to decide about life and death. The difficult thing was where were they going to be in 2 months' time or 3 months' time, and what was their quality of life going to be. And putting that God hat on is not easy. But now when you've got a very limited crit care resource and you've got to think about that patient and their treatment and the resource that that's going to absorb that could be directed elsewhere, it's become increasingly difficult. And certainly as a consultant in our trust, we're very heavily involved in the immediate and actual delivery of emergency surgical care. And NELA, the National Emergency Laparotomy Audit, demands that we're at the table for anybody with a predicted mortality of over 10%. Next slide, please. So this is what I do, what I used to do in my day job, and there's no such thing as a hernia repair now. Next slide, please. These people are waiting, and unfortunately, this chap will no longer be able to get his operation for some months in our practice. This is going to be this is like somebody waiting for a hip replacement. But this young man can't earn his living, he can't support his family, he can't go and earn his wages, and there's tremendous psychological morbidity. There's a lot of psychological heat coming down the airwaves between patients and their doctors now. It's all starting to brew up about why you can't look after me. Oh, there are celebrities who are having their treatments, why can't I? It's really starting to kick off, and I think it's going to become increasingly difficult for doctors and surgeons, and I think the waiting list isn't just going to be a number. I think it's going to be a source of great stress for surgeons going forward. Next slide, please. But going forward, we have to have something new. Next slide, please. I've shown you these figures, about 4.7 million waiting for an operation. And I have to say, I agree with what's been put out, and I personally think what's been put up by the Royal College of Surgeons in England, I think is right. I think we need COVID-light elective surgical treatment centres. I think that we need new job plans. I mean, would you hire a consultant surgeon and only have them operate a day and a half a week? What's that about? Why not have them operate 3 or 4 days a week? And why not employ people to do all the stuff that they're doing in their place? There are obviously other things to do other than operate, but the UK NHS, the English NHS consultant contract, we do not operate enough, and we need to operate more, and we will certainly need to catch up on the backlog. We need to make up some of the ground that we had in COVID, in the initial surge, about autonomous surgical teams and their behaviour. And we found that rebuilding of the team really promoted a lot of enthusiasm and promoted a sense of well-being among trainees. The enhanced training, a facility like this would actually enhance training. They could do immersion blocks of training in the same way as we're starting to see in colonoscopy, and enhance their development and responsibility. UK surgical trainees often, I'm saying UK, I'm talking about England and the Northwest where I live, we maybe don't give our trainees enough true responsibility. And then we have to look at integration of services and how getting the numbers up where blocks of people are doing high numbers and improving outcomes. This will necessarily require some investment, but will have huge benefits in my view. Next slide, please. So the first quote may or may not be attributed to C.S. Lewis, but what we're seeing now is the ancient Greek notion that change is the only constant is certainly true, and we've got to learn to change and change fast, in my view. Thank you very much.
Well, Kieran, thank you for a very thoughtful presentation. I have to say I don't think anyone has reflected quite as deeply about it as you, and I'm left with several questions for each of you. The first is, what about the rusty surgeon, the surgeon who actually hasn't been doing the complex, major but scheduled procedure? And find, like Kieran, when you come to do these really big component separation repairs of the abdominal wall, and you haven't done one in 6 months, how will you deal with that? Because certainly the rusty surgeon is a tricky thing. I've heard about the rusty pilot. Because it's not because you've lost the skill to do it, but it's just the whole sequence and safety of it. Maybe, Kieran, I can start with you.
Thanks, Mr. President. I agree with you, but the only thing I bring you back to is the case you scheduled for after your 2-week summer holiday. And you don't put on the the pancreatic duodenectomy to be done with the robot with your hand tied behind your back and one houseman. You plan. You have to plan. We know that we get rusty. I totally agree with you. I think we have to be match fit as surgeons, and I totally agree with that concept. The only thing that I think that's going on is that we're doing big, ugly emergencies. And I think that is protecting us from the concept that you might raise. I mean, we're seeing people coming in states of disrepair, the likes of which I've never seen. And when they've been hiding at home because they're afraid to come into our hospitals, they're afraid that they're going to get a disease that they don't want to have in our hospitals. I had a woman say to me recently when I told her that she had metastatic lung cancer, she said, "Thank God, I thought I had the bloody virus." And that's what's in some people's heads and why they're staying away. Yeah. And so we are seeing a lot of urgent big surgery to do. So, but your point is very fair. And I think the planning needs to be very careful. I work a lot with plastic surgeons. And whilst surgeon operating is one thing, 2 discipline operating is really tremendous for these big cases. I think it's just fantastic. And you can oscillate responsibility. It can be difficult for trainees and fellows. We had to send our abdominoplastic fellow back to the States early in the year because they couldn't offer him a fellowship experience, but he's just come, sorry, not from the States, from North America, from Canada. He's just come back. But I hope that goes some way to answer your question. I think the big nasty emergencies are protecting us from getting too ring rusty.
And Siobhan, the free flap, if you haven't been doing them, if you haven't been doing the flaps for tram flap for reconstruction, what do you think?
Well, we did have a 6-month period where we didn't do any free flaps, apart from trauma, and the trauma does give you the opportunity to keep your microsurgical skills up, but the free flap breast reconstruction, definitely phone a friend, and two consultant operating has become the norm. Previously we'd have a fellow, maybe a registrar, but and only for the bilateral cases would we have 2 consultants, but I think it's going to persist for a while. And there's a lot to be said for surgical memory as well. You kind of remember, but the first one was a bit scary, yeah.
Paul, no chance that you'll ever get rusty.
Yeah, well, you're certainly absolutely correct in saying that we're not doing regular simple gallbladders, we're not doing simple hernias, we're not doing straightforward uncomplicated diverticular cases, but the cases we are still operating on those, but they're all emergencies, and they're strangulated hernias, obstructed, difficult incisional hernias that should never get to the position that they do, and you know, we're doing more difficult operations than we have been doing in the past because things are being neglected. We're also doing our cancer surgery, but we're getting more advanced cancers. I mean, we're not seeing the simple, straightforward right hemicolectomies that can be done beautifully laparoscopically. We're seeing people presenting with masses and pain and infiltrations and perforations. So we're doing more difficult surgery over the past year. So I don't really think it will be a big problem.
I mean, it's interesting you should mention right hemicolectomy. The number of right hemicolectomies done in Ireland in 2020 was 50% less than 2019. And of course, this is the cancer that's picked up with an anemia. It's picked up by screening or the FIT test. And I have never seen at our MDT the same number of advanced right colon cancers that I'm seeing now.
Extraordinary. You're absolutely right.
Yeah. Michael Floyd has just, and nice to hear from you, Michael, has just put a word in to say urology is not mentioned, but in the specialty they've seen streamlining referrals, cessation of all reconstruction, and a backlog with reduced activities for trainees as well. Thanks, Michael. Brendan, I'm not sure if it's Brendan Moran, is asking, how do we protect ourselves and our colleagues from the medical legal surge? And I'll just expand that to say the GMC and the IMC, and I've been in correspondence with the chair, the president of the IMC regarding this, because the name over the bed is going to be the target for complaint if somebody is delayed and the diagnosis is delayed. Paul, what's your view on that?
We're certainly seeing an increase in complaints. They're not being directed at us in particular. They seem to be going to the health board, and we've seen an increase in medical legal complaints that require defence from the Central Legal Office in Edinburgh. And I'm fortunate to have come across quite a number of those, and a lot of them are to do with delayed diagnosis. So they're people that haven't been referred appropriately by their GPs because they haven't been seen, or because they've had a telephone consultation, which, as you know, is inadequate. And you've also got people that are delayed, particularly for colonoscopies, or for CT scanning, or for even reports of their imaging, not getting referred on to tertiary centres for consideration of liver metastasis or lung metastasis surgery. And yes, there's going to be an explosion of complaints about this. I have no idea how the NHS is going to respond to that.
And Siobhan, you mentioned about skin tumours. I mean, a video clinic is all very well, and if I can put my nevus up in front of you, how can you tell me whether this is something that needs to come off or not?
Well, we normally have a dermatologist who tells us that.
And how does the dermatologist
tell us exactly what needs to be done afterwards? So it does help with planning surgery rather than diagnosis. I agree. Yeah, it's not appropriate for diagnosis. I mean, unless it's barn door melanoma.
Kieran, how are we going to catch up? I really do. I do get it that if doing what we were doing plus 15% is simply not going to change it, and we're not going to get 30% more operating rooms. Does this mean we as a profession are going to be working Saturdays, Sundays? I was, as you know, and I think you were at the Mayo Clinic as well. There was.
I was in Cleveland.
You were in Cleveland, yeah. But that you were either a blue surgeon or an orange surgeon, and you worked as a blue surgeon 3 days in OR this week and 2 days next week, and vice versa. And they had physician's assistants doing a lot of what we would have called scut work.
Well, we're going to have to look at it in a variety of ways, but I think that we need to operate more. I think we need to have conversations with the Royal Colleges and the GMC about bringing senior trainees into more responsible roles and being it acceptable from a medical legal perspective. In fact, the reverse of what was done in the States was stopped being done, was maybe attendings or consultants running a number of rooms at the same time with senior trainees or fellows. Maybe we really need to start looking at this differently. But I think we need to do volume. I think we need to subspecialize and do volume and have teams around us who really know what they're doing and churn through numbers of cases. And I don't mean churn in a rude or inappropriate way. I mean, just get through the work. And I think it'll offer outlandish training opportunities, in fact, because people will be able to come and do sessions of that number of cases. So and I can't think that it means that we should be just doing surgery 1.5 days a week. That to me has got to change, and we've got to employ other people to facilitate doing the chores that we spend the rest of our time doing. I don't know the answer, but it needs a truly fresh thought, and I suspect the colleges and the specialty associations, that should be their possibly one of their number high on their agenda list of how to change this. But here it's a staffing problem. It's not just surgery, it's our staff, our theatre staff. You know, delays in colorectal surgery in the world at the moment and complaints. We have 2 secretaries who are in their surgical office who are desperately ill with COVID, life-threateningly ill with COVID. And we haven't had, you know, it's all been picked up and things. Yeah, it's very difficult, really difficult.
Michael Floyd has just come back to say, do you think we need 3 sessions in a day rather than 2 sessions? I think we probably do.
My worry about sessions is work expands to fill the time allocated to it, and if you call it 3 sessions, you'll find there'll be another hour on the anaesthetic time, there'll be another hour on the transfer time between cases, and then another hour on the recovery time. And the next thing you'll find is you might not get through more cases. You might not get another case done. I think maybe we need to not be thinking about lists. Maybe we need to buy theatre slot time, buy cases, get cases done. Not even think about a list. Maybe the concept of a list is actually an anachronism. Maybe we need to actually reinvent how we board cases for surgery. But whether it's a 3-session day or a 2-session day, we've got to get through more cases. We've got to streamline our workforce, our teams, and we've got to be more productive.
I was interested, Siobhan, that you were able to get breast cancer reconstruction, mastectomy reconstruction up from P4 to P2. This has been something that's been in the media here in Ireland this week, where a lady was told she simply couldn't have reconstruction. What's been the experience?
Well, as I said, initially all reconstruction was off the table. So patients, and even some radiotherapy was off the table. So it was mastectomy or nothing for most breast cancer patients in the first couple of months. But yeah, I mean, it depended where you were working. Certainly places like Norfolk, where they had quite a low COVID whatever impact, they got going again very quickly. And even Liverpool, Whiston, your sister hospital, Kieran, they managed to keep going, get going in June, where it took us till September to finally get the go-ahead. But there was a lot of lobbying by ABS and BAPRAS, the 2 associations, to get immediate breast reconstruction of any kind, whether it was implant reconstruction, which is the majority, or autologous reconstruction, which is what we mainly do. But it was eventually, with intense lobbying, it was approved. But the restrictions that were very, very complex. The BMI restrictions, you know, patients had to be they had to be fighting fit. There could be no comorbidities. It was very restricted.
So if I was overweight and a smoker, would I get my mastectomy reconstructed?
No, probably not.
Can I ask about vaccination pre-op? I was interested to hear, Kieran, you were vaccinating pre-op. This is a really contentious issue, and one I've actually been in correspondence with all the various people in Ireland about, and they're kicking the can down the road a little bit. But it does strike me that vaccination at the time of diagnosis of a cancer, where there's a time-critical surgical intervention, is critical. Your views?
So we thought that, but we can't act as even as an independent trust. We couldn't do that. We had to have the support of the Cancer Alliance, and we've had a formal notification now from the Cancer Alliance that this is going to be practice. This is going to be our practice in our region. I can't speak at a national level, but I'm fairly sure the Green Book, I'll take, there may be others on the call who know this.
The Royal Colleges have written to, and I've forgotten his name, but he's the vaccine czar from Manchester, the respiratory person there.
But we're certainly, our Cancer Alliance, Ronan, has that's where we started.
Paul, are you vaccinating in Scotland?
Well, we are vaccinating in Scotland, but it's been slower than expected. We have the unusual circumstance where there are some nursing staff in our hospital that have not as yet been vaccinated, or it's only happening this week. And I'm talking about the first dose of vaccination. So there's certainly no question of patients being vaccinated at this particular point. They're self-isolating and they're having COVID tests, and that's basically it.
I mean, one of the risks, of course, is nosocomial acquisition of COVID.
Yeah, absolutely, and that's been a real issue. And we certainly had patients having Whipple's procedures and having major colorectal resections or pelvic clearances. We've had people die of COVID contracting it in the hospital. I mean, there is no doubt that it's a real thing, and it's an absolute tragedy. I mean, it's very hard on the nursing staff and on the surgeons dealing with these people. And there's going to be a very high price to pay, I think, for this in the longer term.
Well, I hope that this time next year, Kieran, you'll be reflecting back on your high-speed train 2 years previously, but looking at the disruptive innovation of 2020 and looking at all the favorable things that have come out of it. And that all of your wishes on your wish list on your last slide have come to pass. It's great to catch up, Paul. It's great to see you. And the best to Jackie and Siobhan. Thank you very much for joining us and for giving such a great presentation. Thank you to all who've joined us this evening. I think it's been a great chat. I've enjoyed it. And I look forward to seeing most of you next week. Keep safe.
Cheers.
Thank you very much. Thank you all.
Bye.
Bye.